Yeah, and I welcome everybody in these quite difficult times. I know in Australia you have a lot of problems with flooding over several areas. In Europe we have problems with having war in Europe again. But of course we still have to take care of our patients. And as mentioned already, the topic of today is ROTEM in liver disease and transplantation. And I know that not everybody is dealing with liver transplantation, but I think nearly everybody has to deal in more or less daily practice with patients with liver disease, which can be challenging to understand whether these patients have more a risk of bleeding or more risk of thrombosis. And that's something we want to discuss in this webinar. A little bit about my background. I'm a senior consultant for anesthesiology, emergency and intensive care medicine, and hemostasiology, and worked 26 years at the University Hospital of Essen in Germany. So we started with goal-directed bleeding management using ROTEM in 1998, first in liver transplants, and then also used it more and more in other settings like trauma, cardiac surgery, pediatrics, ICU, and of course nowadays also very important in COVID-19. I was also a section chair for clinical hemotherapy and hemostasis management in the German Interdisciplinary Association of Critical Care and Emergency Medicine, and also worked in the scientific subcommittee Transfusion and Hemostasis of the European Society of Anesthesiology. And of course, most important for my conflict of interest is that since 2012, I'm the global medical director of TEM Innovations, which is since several years now also part of Werfen. A very important point is if we have to deal with a challenging situation, we have to think about the proper questions to ask. And I will also ask you some questions in the beginning where we use a poll everywhere. And that's the link you might enter into your smartphone, because then you get the poll questions directly on your smartphone. And you can just select the answer you want to use, and then it will be integrated in the presentation. I think also the link was put into the chat, but I will just wait some seconds that you have the possibility to enter this before we start with the poll questions. And then after the questions, which just give me also some idea how you're actually working or dealing with these problems, we try to discuss what's the best way to assess hemostasis in patients with chronic liver disease, what's the best way to treat, and then, of course, also what is the impact on dealing with patients with liver transplantation. Well, but that's maybe just the peak of the iceberg when we talk about patients with chronic liver disease. So again, we just wait some seconds that you have the possibility to enter this. If the time was not enough, you can also look at the chat where also the link is mentioned. Just also double check that it's working on my phone. So then we move to the first question. I just see what are the answers from your side. So I see, more than 50% have to deal with patients with chronic liver disease once a month. So sorry that I missed an N in month, but and some is really rare, but in others it's more or less a problem which they have to deal with every week. And I think yes, this is something. If you are working in a specialized hospital or university hospitals, maybe even nearly every day, But I think something between every week and every month might be what fits for most of clinicians. And we're just going to the next question about which statement regarding hemostasis in cirrhosis is correct. Is that A, that increased INR is associated with severe bleeding in cirrhosis, or B, that increased INR overestimates the risk of bleeding in cirrhosis, or it's C, that increased INR proves autoanticoagulation in cirrhosis, or is it D, that low platelet count is associated with severe bleeding in cirrhosis, or that factor 8 and von Willebrand factor are low in cirrhosis? So that's what I more or less expect, is a quite big mixture. Yes, the majority, that's something I would agree, and we will discuss later, that increased INR usually overestimates the risk of bleeding in cirrhosis. And even if you look at multiple guidelines, if it's the ESA guidelines, if the guidelines from gastroenterology and hepatology, more or less they agree that an increased INR in cirrhosis is a marker of the severity of the disease, but it's not a marker of severe bleeding. And yeah, nobody choose the option E, because that's just the opposite, that factor 8 and von Willebrand factor are very high in cirrhosis. And that's one reason why just looking at the INR, which is only considering factors from the extrinsic and common pathway, overestimates the risk of bleeding, because that's compensated by factor 8 levels, which are up to 300% of normal. But we will discuss this later on. The third question is about which statement regarding blood transfusion in patients with chronic liver disease and/or GI bleeding is not correct. So it's RBC transfusion increases mortality, fresh frozen plasma transfusion increases mortality, platelet transfusion increases mortality, blood transfusion is not associated with TACO and TRALI in chronic liver disease, or the last option, portal hypertension is associated with bleeding in cirrhosis. Yeah, of course. The question with 2 times not is more or less mathematically, that's in the end, it's 2 times no. But I also agree with the majority, because we know that blood transfusion is associated with transfusion-associated circulatory overload and transfusion-related acute lung injury. And it's true that the best predictor of bleeding in cirrhotic patients, it's portal hypertension. And that's maybe the main reason why in this setting, red blood cell, liberal red blood cell and plasma transfusion is associated even with an increase of bleeding and also an increase of mortality. And then we have the question, which statement regarding viscoelastic testing in patients with chronic liver disease is correct? So viscoelastic testing, or guiding transfusion by viscoelastic testing, results in more blood transfusion. It results in more thromboembolic events. It better reflects the rebalance of hemostasis and the bleeding risk. Viscoelastic testing is inferior to standard coagulation tests, or last option, viscoelastic testing is not needed, since a 1:1:1 ratio perfectly covers the transfusion needs in these patients with cirrhosis. So we have more or less a 100% agreement, and that's more or less, I think, also the reason why we stop the poll questions and now really going into the details. And thanks for your participation in the poll questions. So again, we are coming back to important questions to ours. And we know that doing lab tests, we have different questions. One question is, for example, if we are running lab tests the day before surgery, of course, our question is, will my patient bleed? And this is a very difficult question. So prediction, that's from Niels Bohr, prediction is very difficult, especially about the future. And that's the same with lab tests, because we know that the so-called positive predictive value for standard lab tests as well as for viscoelastic testing is quite low. And that means we can have pathologic results like an increased INR, but the patient will not bleed the next day. Or we can also have the opposite, that everything looks fine the day before surgery, but then during surgery, the patient develops a coagulopathy and might have a severe bleeding. So when I was asked 10 years ago, what is the best predictor for bleeding? I usually said, okay, I'm looking at the operation theater schedule and say, okay, what's the procedure and who's the surgeon? And then I can predict bleeding much better than with any lab result. This is, of course, also has been assessed in several studies. Here, one from 2020 in Circulation, so a very good journal. And the question was, do we overestimate the bleeding risk, in particular looking at PT-INR? And there's a clear message that plasma and platelet transfusion, which is still in a lot of hospitals standard practice before invasive procedures, if there's an increased INR or low platelet count, should be avoided, because most of the cirrhotic patients are even in a prothrombotic state. And we can see this by comparing. We have an increased INR, but more than 50% of these patients have at least a partial portal vein thrombosis, which should not happen in a patient with a high bleeding risk. And this is also a paper from 2020, even from patients with acute liver failure in Australia and New Zealand. And we are still looking maybe not at the right tests, even preoperatively. We are still focused on tests which are reflected by clotting times, like PT or APTT. But what is maybe even more predictive for bleeding is the fibrinogen level, which is not assessed as a standard, but seems to have the highest predictive value for bleeding, even if all the values the day before surgery have not a very high predictive value. And overall, you see a lot of blood products are given. Nearly 60% of the patients gets fresh frozen plasma, 40 cryoprecipitate, or 1/3 platelets, and about 15% proton beam complex concentrate. And we have to rethink if this is really or are adequate interventions, or maybe they have even a higher risk of harm when we do this in a prophylactic way. And this is a study even from last year. So you see there a lot of people are actually working in this field because it's still an unsolved problem. And what they did in this systematic review, they were looking at the predictive value, or even here, what does the pattern which we see from standard coagulation tests or viscoelastic testing show us in this patient population. So here, when we look at patients undergoing liver surgery, and usually they have also then some liver disease, viscoelastic testing showed in 77% that there is a rebalance, so there's a normal coagulopathy. 18% even showed a hypercoagulopathy, so too high clot strength, and about 4.6% a hypocoagulopathy. If you look from the same blood sample at the results from conventional coagulation tests, they are only normal in 1/3 of the patient population, and 2/3 shows a hypocoagulability, usually prolonged clotting times, or reduced platelet number, and none of the patient showed a hypercoagulopathy. So what was really the outcome of these patients? So no patients experienced in this study significant postoperative hemorrhage, but 5.8% experienced postoperative thromboembolic events, which is very close to the 4.6%, which even were predicted by viscoelastic testing. So the conclusion also of this study was, or of this systematic review, that global hemostatic testing provides a more robust assessment of coagulation status in patients undergoing liver surgery. And we should be very careful using INR or platelet count for at least prophylactic intervention, so to correct numbers. And it's more maybe a therapy of the feelings of the attending physician, that we feel better when we correct these numbers in advance. The other question is, if we are in surgery and the patient is bleeding, why does my patient bleed? Which is a completely different question, because now we want to identify the reason for bleeding. So it's not a question anymore if there's bleeding or not. This is a precondition that there is bleeding that we can answer or think about this question. And of course, we can also sometimes just look at the surgical field, or sometimes even at the floor. And usually I say when the blood comes up to the face of the surgeon, it's a surgical bleeding from a high pressure area. And when we have a blood on floor syndrome, it's more or less a waste of time to discuss if that's surgical bleeding or coagulopathic bleeding, because after some time, it's definitely a combination of both. But here we can use a quite high negative predictive value of viscoelastic testing for bleeding, which means this is between 90 and 97%. So what means negative predictive value? We can go through a protocol and we can exclude reasons for bleeding. For example, if we use a FIB-10 clot firmus, and this is higher than 10 to 12 millimeters, we know that adding more fibrinogen will not be helpful. Or if the clotting time is low, giving plasma or PCC will not be helpful. So the chance is just 3 to 10% that it has any benefit, but it's more than 90% that there is no benefit. And I know this is a busy slide. This is from a study from my colleague Fuad Zahner. He is running the liver transplant ICU in Essen. And in this study, it was even the question, since we use viscoelastic testing, so ROTEM-GUIDED protocol, for more than 20 years in the liver transplant population intraoperatively. The question was, when the patient comes to the ICU, if we can again predict bleeding. And it's just to show you how the concept of identifying an optimum cutoff value and about the positive and negative predictive value in this situation. So what we see is that we don't use reference ranges because, patients with chronic liver disease are not normal healthy volunteers. So we have to double check what are really their needs. And you see here, for example, when we look at the PT in percentage, so the quick value, they don't need 50% of the activity, like an INR 1.5. They are still happy with about 30%, which corresponds to an INR 1.8. And you see, even if we are below 30% of the normal activity, there's only a positive predictive value, so a chance to bleed of 24%. So again, if we correct all the patients, even with an INR of higher than 1.8, we might treat 75% without any needs. However, the other way around, if we have bleeding, now we can use it, but it's a negative predictive value is 91%, but we will see that viscoelastic testing is even superior. So we see here that when we compare the PT-INR with the clotting time in XSTEM, you see that the negative predictive value is much higher because of the XSTEM CT, because the chance to do something wrong is here only 3.3%, and here's 9%. So that's 3 times higher. But what we know, of course, is that clot firmness parameter, if you use here the A10 in XSTEM or the A5 in XSTEM or in FIB-10, you see that clot firmness parameter seems to be even more important. And again, if we have, for example, a clot firmus, here an A10 in FIBTEM that corresponds to 1 millimeter less as a A5 in FIBTEM. So again, if we have at least 12 millimeters in FIBTEM, the chance that we have to increase the fibrinogen level is extremely low. So this is the way how we develop these cutoff values and integrate these cutoff values then later on in algorithms. And this has been done also here from the group from Luc Mazicotte in Montreal in Canada. He's very famous for using very low blood transfusion and liver transplantation in his unit. And he's even doing in a lot of his patients a phlebotomy at the beginning to reduce the central venous and portal vein pressure. So he has just a transfusion rate of less than or about 40%, but this is for intra and postoperative. So for intraoperative, it's usually below 20%. However, what you could identify was that the FIBTEM clot firmus, if there was bleeding and if they had to consider blood transfusion, was the best parameter to predict intraoperative and postoperative blood loss. So that means, again, as I mentioned already, for the preoperative assessment, where we should use just the standard fibrinogen more often to get an idea how we start, also for the intraoperative management, the FIBTEM clot firmus seems to be one of the key parameters for optimizing the management in this patient population. And of course, there's again an increasing number of studies. There's one big study from the acute liver failure study group in the US, where we did together some years ago and published last year a multi-center observational trial. And we were looking in this study at patterns, so that we even look at test combinations and also on the dynamic of the situation. And that we see in this quite busy table. So just to understand what we are showing here is in the left box, we are looking at the bleeding risk for, or the pattern of patients where we have no bleeding. You see there's a lot of green, where in the right box, that are the patient with an increased bleeding risk. And you see at admission, that's the left column, it starts quite normal, and over the time, there's no significant deterioration, where in the patient which develop bleeding problems, even at admission, there is still quite a lot of green, but already at day 2, and then it gets worse and worse, there are significant changes. So the point is we will not find one single parameter which gives us all the information. And it's also important how the situation is changing. That's something which we just see also, of course, in COVID patients, that we also have to look at the dynamic, in particular at the critical ill patient. But this is, of course, a topic for another talk. And also we can look not only at the risk of bleeding, we can also look at outcome. So here again, you see on the left side, it's a transplant-free survival. So the patients who survive and don't need a liver transplantation were on the right side, and you see here's much more red and black. That's the pattern patients present, which finally don't survive or need a liver transplantation to survive. The other question is, of course, if we have bleeding, how to fix it? And there, of course, are different strategies. One is just to refill. So if blood is running out, we just add new blood and hope that bleeding will stop at any time. Or, and that's more the way how we are working actually, is to close the holes. But then we have to identify the holes, and then we have the opportunity very specifically to close the holes, because I think the therapy of bleeding, in particular in chronic liver disease, is not just to transfuse, is to stop the bleed. And again, for that, we have to know why the patient is bleeding. So what's about liberal and restrictive transfusion in patients with chronic liver disease, or as in this study published nearly 10 years ago in the New England Journal of Medicine, in patients with acute upper GI bleeding. And they have, of course, very often a chronic liver disease. And what we see is that patients with restrictive transfusion in this clinical setting has definitely an increased survival. You know, there have been done a lot of studies about restrictive and liberal transfusion, and in most studies, the result was, okay, it doesn't really matter. So we can do restrictive transfusion, have the same outcome with liberal transfusion. But again, in chronic liver disease and GI bleeding, this is not the situation. Here we have definitely an advantage of restrictive strategy in regards to outcome. And it's the same if we talk about fresh frozen plasma. No, this is still a meta-analysis here, I'm sorry, about red blood cell transfusion. So there have been several studies, and in 2017, a meta-analysis has been performed, which just confirmed the single study, which has been published 4 years before, about red blood cell transfusion. And you see, when we look at all-cause mortality in patients with GI bleeding, that the relative risk for mortality was 0.65 for the restrictive transfusion. So that means there's about 1/3 less mortality. And the interesting point is this is not associated with more bleeding or rebleeding. It was even the restrictive transfusion was associated with less rebleeding. And here the rationale behind is, again, that liberal transfusion results in portal hypertension. And again, this results in more bleeding. Here we are in the study looking at fresh frozen plasma transfusion, and it's also just a study, it's less than 1 year old, where they were looking in a multi-center cohort study on the effect of fresh frozen plasma transfusion and 40-day mortality. And the odds ratio for mortality was 9.4. So that means nearly 10-fold increase in mortality with liberal plasma transfusion. And at the same time, plasma transfusion was associated with a failure to control bleeding at day 5 and also with a prolonged length of stay at the ICU. So that means, yes, we give more products, but we increase mortality and even don't control bleeding, because fresh frozen plasma is not effective to correct the coagulopathy in cirrhotic patients, but it's very effective to increase portal hypertension. And even if we look at platelet transfusion, this is just the most recent study. It has been shown already in Groningen in the Netherlands 10 years ago that liberal platelet transfusion is also associated with increased mortality. So even if the platelet count is quite low, we have also to consider, for example, the very high levels of von Willebrand factor, which even makes a small platelet count very sticky. And we should be very careful with platelet transfusion in this setting. So just to summarize this, and this is from an editorial, Furzan and me were invited 6 years ago, that when we look at the data, 30 to 90% of plasma, and this is also true for platelet transfusion, is performed in an unnecessary way and even put patients at increased risk due to transfusion-associated circulatory overload, transfusion-related acute lung injury, and transfusion-related immunomodulation. So on the one hand, we are wasting important resources, and on the other hand, even we might harm our patient with prophylactic interventions here. And of course, this is not a new discussion. You see, that's a paper already 12 to 13 years ago. again, from the group from Groningen in the Netherlands, and just pointing out again that the most often reason for bleeding is an exacerbation of the portal hypertension. So we should be very careful with fluids and blood transfusion, because this very often results in portal hypertension and even more bleeding. So it's very important to monitor our patients closely from the hemodynamic situation, but also from the hemostasis situation, and really only give what is needed. And one way how we were working in the last 20 years in this field is moving more and more to factor concentrates, of course, only if they are needed. We should also be restrictive with factor concentrates, but we can use these products to treat a coagulopathy without giving a lot of volume. And that's something also very important in this field. There's also a quite interesting randomized study from Brazil, because in this study, they were comparing 3 different concepts in patients who need an invasive intervention, for example, to put in a central venous line. And the concept were to use standard coagulation test, to use ROTEM or viscoelastic testing. But I have to say, in this study, they used the algorithm also for the decision if a prophylaxis was needed. So I think this is not really the adequate use of a protocol, because our protocols are used in bleeding patients to use a negative predictive value, or a very restrictive approach, which means don't do anything prophylactically if the INR is not higher than 5 and the platelet count is not below 25,000. And in the end, in this study, to be as restrictive as possible was finally associated with the best outcome. So that brings us to the question, why are we performing viscoelastic testing or ROTEM-guided bleeding management? We have to understand this as an essential part of patient blood management, in particular the second pillar, which means minimize bleeding and blood loss. Again, we can also discuss the third pillar, going beyond just to improve tolerance to anemia. We should also expand this, from my point of view, to other blood products. So not only be restrictive with red blood cells, we should also be as restrictive as possible with plasma and platelets. And finally, it's about patient safety. And you know, Hippocrates already 2,500 years mentioned that, of course, as physicians, we would like to cure, but maybe it's more important to avoid additional harm. And that resulted in the development of protocols, as I showed before, using observational studies, and then using the cutoff values we created in the observational studies in these algorithms in patients with bleeding, and using the negative predictive value. That's just an example here, which is published in between in several also textbooks, like the textbook from Yuntaruya from Houston about management of bleeding patients, and also Liver Transplant Atlas, just published more or less 1 year ago. It's always using more or less the same concept. First, check the clinical situation, and then going through the protocol, if there's any indication to give an antithrombolytic drug to increase clot forms, to increase thrombin generation, and then also to restart the algorithm if there is ongoing bleeding. Overall concept is that we only want to administer the right hemostatic drug or intervention in the right dose at the right time and in the right sequence, and to avoid any inappropriate intervention, if that is allogenic blood products or factor concentrates. And that means we don't treat numbers, because that might increase the risk of thromboembolic complications. Of course, we can also adapt the protocols to the pediatric situation because we have more and more studies also in this field. The concept is the same. Cutoff values might differ a little bit because usually the pediatric population have a different pathology. Very often it's a biliary tract issues at the principal problem. And these patients even have a higher risk of thrombosis compared to the adults with an alcohol or virus reason for cirrhosis. What we also know that there is a rebalance of the system. So some factors are low, others are high. But the key message is that this is counterbalanced. So to push, for example, with prothrombotic drugs or blood products may move even more the risk from bleeding to thrombosis. What we know, again, here in a systematic review and meta-analysis, that using viscoelastic testing is definitely associated with less intraoperative bleeding as well as blood transfusion. And this is true for all kind of blood products, whether this is fresh frozen plasma or platelets. And since both plasma and platelets are associated with increased mortality, again, we should be as restrictive as possible and definitely avoid prophylactic interventions to correct numbers. This is a study from my institution in Essen, where they analyzed more than 370 consecutive adult liver transplant patients in a study. And they were looking at the transfusion rates. About 50% gets some fibrinogen concentrate during liver transplantation. Proton beam complex concentrate is much lower, less than 20%. Also platelet around 20%. Tranexamic acid, we stopped the prophylactic use in 1999. It's about 4.5% because we know that even you have some hyperthrombolysis at the reperfusion, this is usually self-limiting, and we can even use this as a predictive factor for early graft function. And like in the group from Luc Mazicotte in Montreal, about 60% get some red blood cell transfusion. One interesting point was that usually the administration of fibrinogen did not increase mortality, except we have really to give very high amounts, more than 8 grams, which is very, very rare in liver transplantation. That just means that we really have an uncontrolled, quite often also surgical bleeding. But here we are talking about maybe 5% of the population who really have this issue. On the other hand, the use of platelet concentrates was highly associated with mortality. That's nothing new. Already a lot of studies published this, that giving platelets more or less doubles mortality. Also, the infused volume per liter, so 13% increased mortality per liter of volume, has a quite high association. And you see that what we mainly use, the MELD score, yes, there's some prediction, but here we are talking about 3.9%. So let's say 4% increase. So what is more or less in the focus has the lowest impact on mortality compared to infused volume or even giving platelet transfusion. So the conclusion was that a ROTEM-guided use of factor concentrates avoids what is not needed, and by using this concept, these more than 370 consecutive liver transplant could be done without any drop of fresh frozen plasma. And again, I think if we have to treat a coagulopathy, I think with small volumes of factor concentrates and if any possible, avoid platelet transfusion might be actually the best way to deal with this patient population. But as I said, we're not only talking about liver transplants, we're also talking about patients undergoing invasive procedures with chronic liver disease. And this is a study from Italy, which showed again that if we use a ROTEM-guided approach, here 2/3 of all platelet transfusion could be avoided. And I think this is an important point, and this is a study from our hepatologist from the University Hospital of Essen. And you could see here that there was no reduction anymore in plasma transfusion, because even our hepatologists don't use plasma anymore. But what we see is that even when we talk about PCC, sorry, you see that in the ROTEM group, which might reflect better thrombin generation compared to INR, only a very small number of patients were treated with PCC. Also, when we look at platelet concentrate, this was going down significantly if we showed a rebalance of the system, and some patients were treated finally with fibrinogen concentrate. But the most important message is that most of the intervention are just not needed. It's not just to shift from allogenic blood products to factor concentrates. It's more to identify the patients who have a rebalance and don't need any prophylactic intervention. On the other hand, we know that there is an increased risk of thrombosis, and that's in particular in the cirrhotic patients, which also have a malignancy. And that's not a big surprise, because that means if there is a malignancy, we have also malignant cells in circulation. And that brings us again quite close to the COVID situation, where not malignant cells in the circulation, but they are cells which express tissue factor in the circulation. And that means here that if we have a combination of a malignancy and high fibrinogen levels, that means we have increased thrombin generation due to the cells with tissue factor on the surface, and we have more substrate. And that means here in this patient population, cirrhosis and carcinoma and high FibTem levels, there was a 5-fold increased risk of portal vein thrombosis. So that means, again, we have to be very careful. And the very similar results, the group here from Khalid Yassin, who worked in Egypt, now is working in Saudi Arabia, showed that also when we look at the tendency or the change in levels, that's intraoperative FibTem values, and then even in this studies, we looked at the FibTem values at day 1 after surgery, day 3, and day 7. And if the FibTem plot firmus at day 3 was higher than 23 millimeters, or at day 7 higher than 28 millimeters, there was a very high incidence of thromboembolic events. So that means, again, the FibTem here can help us not only predict bleeding, but also to identify patients with high risk of thrombosis, and we definitely need an anticoagulation therapy even after liver transplantation. Another point is that we know that there are so-called endogenous heparin-like effects. So we know that during liver transplantation, but also in patients with cirrhosis and infection, we can recognize this so-called endogenous heparin effect. But the question is what to do. Because what does that mean? There is a damage of the endothelial glycocalyx during reperfusion or also in cirrhotic patients with infection. And that means that the heparinoids, which are part of the endothelial glycocalyx in the microcirculation, are washed out to the macrocirculation. And of course, we look mainly at the blood samples from the macrocirculation, but we still don't know exactly what to do, because, for example, giving protamine might even worsen the situation of the microcirculation. That's something we still have to learn a lot about this situation. Coming finally to interventional studies in the setting of liver transplantation. This is a study done at Einstein Institute or in Sao Paulo, which several years ago adapted their protocol to a ROTEM-guided approach. And what you see is that the incidence of any blood transfusion was significantly reduced from 58 to 37%. At the same time, red blood cell transfusion, plasma transfusion was nearly eliminated. Yes, it's still here 7%, but I'm quite sure in between they were still going down. And of course, there was an increase in fibrinogen concentrate and PCC because they didn't use it before. But that's just blood transfusion. More important are the clinical outcomes. So when we look at the incidence of upper GI bleeding, it dropped down from 31 to less than 20%. Any thromboembolic events from 6 to less than 4. Arterial thrombosis, which can be a fatal event in liver transplantation, from 3.5 to 1.9. And in-hospital mortality, which was already quite low with 6%, went below 2%. And also you see that the ICU length of stay as well as the hospital length of stay was reduced. And, you know, for liver transplant, 16 days at hospital is already very short, but 11 days is extremely short. And this has been reproduced also by other groups. It's also here a group from Brazil, which showed at least a quite strong trend to reduced mortality, even on a 1-year survival. But the study was not big enough to show significant results. But I think we are on the right way. And also you see that there's a tend to decrease renal failure. Also a higher rate of early extubation, so going in the direction of fast-track surgery, even in liver transplantation. And that was also here realized in a Spanish group where they even implemented bundles of fast-track liver transplantation. Of course, this cannot be done just by implementing one single point. Of course, we have to run our anesthesia management accordingly. We should avoid strictly fluid overload. They use thromboelastometry in bleeding. And they use also temporary portocaval shunt. So again, a bundle of interventions. And overall, in this study, they included 240 liver transplants, and only a very small amount had to be transfused, and only with about 2 units per liver transplantation. That's very similar to our institution. And immediately extubation within 30 minutes after liver transplantation could be done in all but 4 patients from 240. So here we are just talking about a very small number, and this is definitely associated also with a very good 1-year survival rate in this patient population. And this has, of course, also impact on guidelines. So that's the European guidelines. Just the next edition is on the way, and I think will be published end of this year or beginning of next year. But already in the edition from 2016, there was a 1B recommendation to use a standardized viscoelastic testing guided hemostatic algorithms. When we look more specific in the field of patients with liver disease and liver surgery, there's also here from the British Society of Hematology a 1B recommendation not to use INR for the decision-making of blood transfusion or of plasma or PCC transfusion in patients with liver disease. It's important to use tests which include an heparin inhibitor, which you know we do in all extrinsically activated tests with polybrain, and also we can use the INTEM and HEPTEM to identify a heparin effect. And also they focus on the FIBTEM or functional tests to assess fibrin polymerization to guide fibrinogen replacement in this patient population. And also they point out the very high negative predictive value, which should be used to identify what is helpful and what should not be given. The similar recommendations are here from an international expert group from colleagues mainly from Europe and the US. And also they clearly point out that viscoelastic testing is superior compared to standard lab tests, and that they can be used to develop transfusion guidelines or transfusion algorithm for liver transplantation. Here just an example is shown. And as I mentioned in the beginning, this is not just from anesthesia. Here, these are the guidelines from American Gastroenterology Association. So there's even a good agreement between anesthesia intensive care colleagues as well as gastroenterology and hepatology, where their best practice advice number one is that a global test of clot formation, such rotational thromboelastometry, should be used for evaluation of clotting in patients with cirrhosis, and that pathologic results of standard tests should not routinely be corrected, like thrombocytopenia or increased INR. But this applies also for the viscoelastic testing. They should also not prophylactically be corrected, because this therapy has been shown in a lot of studies is associated with worst outcome. Similar, the recommendations from the Liver Intensive Care Group of Europe, they all go in the same direction, that PT and APTT are unrelated to bleeding risk with a 1B recommendation, and that viscoelastic testing should be preferred for this assessment. But again, we should be careful and not use them for prophylactic interventions, because prophylactic plasma transfusion should be avoided. And we have to assess, when we look at clot firmness, if there's a counterbalance of low platelet count, for example, by higher fibrinogen levels, and recombinant factor 7A should not be used, because several randomized studies showed that there was no reduction in bleeding, but there was a nearly tenfold increase in thromboembolic complications. And I think that's one of the last one, just the American College of Critical Care Medicine, and you just see all the guidelines are going in the same direction. And here again, with a strong recommendation, they say use viscoelastic testing instead of INR platelet count for guiding your decisions. And that's the end of the presentation. So I think in particular in the situation where you have to deal with patient with chronic liver disease, even if we see in the preoperative assessment increased INR low platelet count, this is not a surprise. That belongs to the pathophysiology of these patients, but usually it's counterbalanced by very high levels of factor VIII and forvilibin factor. And that means we should keep calm, not to do prophylactic corrections, because they are very often associated with complications. Of course, we should be aware that this population is on a very low level of balance and can very quickly move to bleeding as well as to thrombosis. So we should be prepared. And if there's bleeding, we should stop bleeding as soon as possible, but not overreact and overcompensate, because at the same time, we should avoid thrombosis. And thank you for your attention, and I'm open for questions.